So for the sake of everyone's time, I'm going to go ahead and get started. Thank you so much for joining me tonight to talk about climate change. And so I'm really excited to be here. And once again, thank SAEM staff for a phenomenal virtual webinar and everything that they have done to make this successful. The objectives for the next 20 minutes or so are here. I'm going to summarize historical quality improvement reports, notably to error is human, and the consequences on medical practice and patient care that we experience every shift in the emergency department to this date. I'll describe the impact of the health sector on US greenhouse gas emissions, and then discuss a few examples that really highlight challenges and opportunities for the health sector to catalyze the changes that are needed to reduce greenhouse gas emissions. I will focus on a report from the National Academy of Medicine that came out a few months ago that discusses health service delivery. And then lastly, we'll be able to apply these recommendations and hopefully give you some resources so that you can be a climate champion in your own institution. Now, I want you to think back to your last shift or the last rotation you were on while you were in the hospital. Perhaps you walked in, logged in, and then you started seeing patients. Think about all the different processes that were in place that helped you be a better doctor and prevent some wrong site surgery, for example, or medication errors. These are a couple of things that I think about, just simple hand hygiene. And then I think about all the steps in place to reduce central line infections. There are so many ways that the quality initiatives of our hospital impact the care we provide. And most of it's for the betterment of our patients and our ability to provide high quality, time-sensitive emergency care. Medication errors, pressure wounds, I talked about surgeries, falls, and the fall bracelets, all the checklists, all of these are good things and metrics that have guided our practice. So how can we use what we know about quality improvement initiatives to apply towards new changes that need to take place within a complex healthcare system? And so I wanted to take you back to 1982 to start and look at a few key books and reports that have really defined the quality improvement processes that are in place. The first is Out of the Crisis. This was a book written by Professor Edwards Deming. Now, he was a statistician and engineer, and he had a brilliant mind when it came to quality initiatives. He in fact, invented many of the different ways that the US Census Bureau does testing and sampling to this date. In his book, he outlined 14 key principles to guide management. Now, there are many, but I want you to think about a couple ways. And so here, it was this idea that it's a continually improving process and that there are vigorous programs of education and self-improvement for everyone. And so out of these principles came this idea of quality improvements and models of care that really guide our philosophies and practice today. You can read the others after the fact. So a few years later, To Err is Human came out. Now this was around 2000, and it was by the Institute of Medicine, which is now the National Academies of Medicine. To Err is Human was really instrumental in changing our idea of patient safety. Essentially what it did was highlight that 44,000 to 98,000 people die every year due to preventable medical errors in the United States. Now this was groundbreaking, but what it did was more. It said there are not bad people working within these systems. There are bad systems in place where these people work. And so it took this system approach into addressing some of the concerns that were harming people, quite frankly. A few years later, Crossing the Quality Chasm came out, a new health system for the 21st century. Again, this was from the Institute of Medicine, and what it did was take a step back, and it showed a broader focus on the faults of the US healthcare system and how systems can really change to implement care. It outlined key steps to promote evidence-based practice and strengthen clinical information systems, as well as strengthen the patient-clinician relationships, looking at key entities like patient satisfaction. So again, it was a whole framework, many different recommendations that again led to these broad stream impacts and changes that we recognize to this date. Now, one of the key entities to think about is this difference between quality assurance and quality improvement. Many of you have probably heard of quality improvement, but maybe fewer about quality assurance. And here's how I think of it. The picture on the left is of Jim Rice. In 1982, he played for the Red Sox, and he was a phenomenal baseball player. He was in the dugout, and a foul ball was hit, and it hit 4-year-old Jonathan in the stands, right in the face. You can see there, blood coming down. And what Jim Rice did was unprecedented. He ran from the dugout into the stands, grabbed the little boy, and carried him back to the dugout. He knew that the team physician was there. He knew that there was an ambulance waiting for the team right behind the dugout, and that was the fastest way to get this little boy to Boston Children's Hospital, where he eventually underwent brain surgery and led to a full recovery. Now, it gives me chills just to think about, because many have said if it weren't for Jim Rice, this little boy would not be here today. And so really thinking about quality assurance in this manner, with a focus on individuals, perfection myth, solo practitioners, errors being punished, and even peer reviewed being ignored. Let's contrast that to the quality improvement process. Again, this is taking a step back and looking at systems. And to me, that comes with the example of nets. So after this incident, more and more baseball stadiums put up these nets in high-risk areas where these foul balls tended to be hit time after time after time again, to protect observers and reduce the harms to patients like young Jonathan. And so when we talk about a quality improvement initiative and process, it's very much systems focused. Fallibility is recognized. There's teamwork, peer review is valued, and errors are seen as an opportunity to improve. And that's the kind of system that we want to be a part of. Now, from that, there was this model for improvement and other processes that take place. Some of you may be familiar with that, as quality improvement initiatives are mandatory for most residents to complete during training, and for many practicing physicians as well. The model for improvement asks 3 key questions. What are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in an improvement? And then there's this iterative process, plan, do, study, act, or PDSA. And this iterative process is so that we continually strengthen our systems and promote high quality patient care. And much of this can be explored more at the Institute for Healthcare Improvement. All right. So that lays the foundation for the quality improvement process and the initiatives that have taken place. Now let's contrast that to some of the new changes we want to make. And that's where climate change comes in, and environmental sustainability in healthcare. Perhaps some of you know that in the United States, 10% of greenhouse gas emissions are from the health sector. Many will say in providing care, we're doing harm. Scientists and colleagues, Drs. Eckelman and Sherman, have done research for years on this topic. And here's what they have to say. The indirect health harms related to these greenhouse gas emissions from the health sector are commensurate with the 44,000 to 98,000 people who died secondary to preventable medical errors in the To Err is Human report. And yet we live in a system, and we go there and work every day, where these harms are not recognized. Right now, these environmental harms are not recognized and taken into consideration. And so as we try and change our ways and begin to address these, how can we do so with a systems framework? I just want to remind you why this is important. Greenhouse gas emissions are fueling a warming planet. And that means warming land and sea surface temperatures, even marine heat waves, if you've heard of them. They're also fueling extreme weather events, any of these hurricanes, tropical storms, the heat waves, as I mentioned, drought, large wildfires. It's exposing people to various entities that ultimately contribute to poor health. And we see the patterns of injury and disease right in our emergency departments and hospitals, changing infectious disease burdens, heart attacks, strokes, traumatic injuries, so on and so forth. And so really, as a healthcare system, how can we mitigate and reduce the greenhouse gas emissions to support this overall global initiative? Now, going back to the US health sector, greenhouse gas emissions in the United States, I said were high, but how do they compare to other countries? And you can see here, we're still an outlier. Now, this is not an entity where you want to be an outlier. We're way over on the right, not good. If you look on the y-axis, there's healthcare access and quality index. We're doing pretty well, but certainly not the best. And that was looking at greenhouse gas emissions from the health sector, and that's per person. Now, if we look at it as emissions per capita, we aren't doing well either. In fact, we're near the top. This is a picture of Iceland, who is the only one ahead of us on some of the studies that I've read and shared with you here. And that's an island. So we are not doing very well. So again, looking at our goal, how do we reduce that? Looking a little bit closer into it, what are the contributions to healthcare life cycle emissions? This is a busy slide, but what I want you to take away is this light blue color. And you can see hospitals are a significant source, and it represents an opportunity for us to transform our system, along with all of the other practices such as pharmaceuticals and so on and so forth. Now, these emissions you may have heard of are measured as scope 1, scope 2, and scope 3 emissions. Scope 3 are the most prevalent. There are direct and indirect emissions. I will not go into detail about these, but recommend you read more about them if you're interested. So that's a macro level discussion on emissions. Now, if we look a little bit smaller at a micro level, how are specific surgeries and pharmaceuticals and different processes impacting the care we provide? And here's the reality. We know what the carbon footprint is of all of these different things. Laparoscopic surgeries and cataract surgeries and anesthetic gases and dialysis and inhalers. But I want to put it within the framework of emergency medicine. So I'm going to give you a few examples, 4 to be exact. So the first one is reusable versus single-use laryngoscopes. And so this was a study done a couple years ago, and it essentially looked at, again, single-use versus reusable laryngoscopes. And as you can see here in the gray, this single-use had much higher life cycle greenhouse gas emissions per use compared with the reusable devices, which are shown here in green. They are also much more expensive. A second example was by Dr. Slutzman and colleagues, who's really been leading the charge in this, is looking at waste and trash in our emergency departments. And so they did a waste audit, and they found more than 4 pounds of waste generated per ED patient encounter, and almost 1,500 pounds total, and a waste that equates to well over 7,000 miles of driving a car. Again, this is one system, one hospital, one ED. What does it mean from a system level? A third example is looking at food and nutrition and hospital kitchen waste. This was another audit done over about 16 hours, and they measured all the different food. And so there was compost and recycling and landfill. And what they found was more than 200 pounds per hour of food waste was generated and almost 11 bags per hour. And you can see here, a lot of it was composting, but still there was a chunk that went to the landfill, and so on and so forth. The fourth example is just a reminder of the healthcare costs related to any of these climate sensitive events. And so this was a study looking at various costs and $10 billion in healthcare costs. That is emergency department visits, hospitalizations related to extreme heat exposure, Lyme disease, wildfires, and all of these different events back in 2012. And why is this important? If we put healthcare costs in the context of our national healthcare system, here's the reality. In the United States, we spend the most in regards to healthcare. So percentage of gross domestic product spent on healthcare is almost 17%. That far exceeds many other countries that are similarly developed, as you can see here. Now, you'd think spending more might mean better outcomes in regards to infant mortality rates and life expectancy, but the reality is sobering, friends. Our life expectancy is far from being the best. And so we are 11th, and you can see the United States down here. So despite spending the most, we are far from the best. And so the question is, where do we go from here? What is next? And really, this is an ask and a call to you all, because just like the Quality Improvement Initiative took charge, how are we as a healthcare sector going to take charge and change our system once again to recognize these health harms that are unacceptable for our patients? And with that, I bring to you this report, 2030 Next Steps to Healthcare Climate Leadership. This was a report put together by Walt Vernon, Don Berwick, and Eric Berzin. And so these are really fundamental leaders within the quality improvement process, as well as nationally in regards to procurement. And so they put together this report. They got a collection of individuals, clinicians and healthcare administrators and engineers and business leaders all together to provide insight. And essentially the goal was this: reduce the carbon footprint of the US health sector by 50% by 2030. And they outlined a framework for doing it. And so the focus was on this: redesigning our health service delivery, redesigning our health service infrastructure, and redesigning our health service finances. Again, a collection of individuals from all over the country sharing their expertise. And so then they posed the question, how might we design a system to get better outcomes? And then what are the next steps in order to implement these new design system changes that we want to take place? For the sake of time, I will just focus on the left side, which is health services delivery, but I will give you the link to the rest of the report if you're interested in reading more. And so here were some of the takeaways, really thinking about it as it is my job. It is my job to address this, and that nobody else is going to do it. Thinking about digital health and in-home care implementation with an eye towards equity. So not just helping some, but helping everyone in your community, especially those who are at greatest risk. Maximizing best practice in clinical delivery. This means reducing overuse. That's pharmaceuticals, that's giving oral drugs instead of IV drugs, and providing high quality patient care, but in a reasonable, thoughtful manner. Maximizing infrastructure and supply chain that is environmentally friendly. This is known as environmentally preferable purchasing. And there's these large group purchasing organizations that can drive some of these changes. Maximize community sharing. This means you want to reduce duplication of efforts. If you have 3 different organizations doing the same thing, how can you take one organization that focuses on one entity, the second that works on this one, and the third that works on this one? Insert climate impacts into definitions of clinical quality. And last but not least, use change management lessons learned from the quality initiative. And so I set the stage of our quality initiative as a reminder of what we can learn from history and how we can inform other changes that we want to take place. just for your sake, depending on your interests, infrastructure, finance, certainly many different opportunities for you to engage, whether it's at building resilience, using implementation science in your research to accelerate needed changes, or encouraging organizations with significant portfolios to divest. And so I'll just wrap up here. There's a few recommended actions for health service delivery. A research agenda. SAEM will be important for that. Developing and standardizing measurement tools and a benchmark framework to ensure transparency and accountability. The digital health redesign, and really amplify climate change as a health crisis and equity issue. There are other recommendations for achieving zero emissions from healthcare on a global scale, and really communicating and activating, as well as linking zero emissions with health equity and climate resilience will be key. We can synergize our efforts. As a SAEM, we can be one of the organizational leaders and catalyze the changes needed within our own system across research, educational, and clinical missions, and really support a new system of transparency similar to the triple aim of healthcare, where we can not only improve the experience of care, improve the health of populations, but reduce the costs. And environmental sustainability in healthcare is without a doubt a pillar of that, not only right here in the United States, but across the world, where high emitting countries, again, have disproportionate impacts on low and middle income settings and small island developing states, despite them contributing the least. So I encourage you all to download the report, explore it a little bit more. Just remember, every system is perfectly designed to get the results it gets. And so it's up to us to design the systems that we want to see that support not only high quality emergency care, but also high quality patient-centered care. Happy to take any questions.
Wow, that was fantastic. I was so impressed with the description of the to err is human, and the report from the QI process, looking at it from a QI lens, might be something that could help us talk to our administrators, especially with the focus on finances, and how, like you mentioned, just using reusable laryngoscopes as opposed to the single-use laryngoscopes, just putting it into their budget, that's going to save them money, and it could be a QI. I think there's so much literature that you've presented that educating our administrators, you've given them the tools that they need. So I like setting goals.
Yeah.
I like the by 2030 timelines.
Yeah. Yeah, it's interesting talking to them, and I've moved a lot in the last few years, and so every place is a little bit different, but this culture of environmental sustainability is just, people think about it so differently. And almost, it's funny because they'll be like, we can reduce our emissions. Like if they transition from coal to natural gas, you're cutting emissions by like 45%. And so you're already reached your goal almost. But is it for the right reasons when you just bought and invested in 30 years worth of natural gas? And so it brings about many challenges. And then it's, again, this continually questioning of like, where should our priorities be, and how do you engage all these different stakeholders that are so necessary to creating these system-wide changes? All right. Well, I will let you all go. It's so lovely to see you, and be well. Get some dinner.
All right.
Jonathan, good to see you.
You too, Caitlin.
Your jam.
Thanks for covering this. It's really so great and super important that everybody really spreads the word even more. And I think it's well beyond us. It's regulators, it's the Joint Commission, it's so many entities that need to get involved to really turn the boat.
Yeah. Yeah, for sure. And Jonathan has been a leader. If you guys don't know, he's been phenomenal. So
I love his nickname.
he's a
The-
wonderful,
Yes.
wonderful human. So SAM, I mean, will without a doubt be in these conversations moving forward. And we have many people interested in this field. So it's exciting. I'm looking forward to seeing what happens. All right. Bye.